Hello. Okay, let's get started. I'm going to be reading Mehlman's High Yield Review, USMLE Review Part 1. I believe there are 4 files, each with about 20 pages. So my goal is to get done with these, at least one in a session. Let's see how it goes. Let's start. Okay. This is weird. I'm doing it on my iPad. I'm not sure if I'm muted. Usually do it on my laptop, but anyway, let's start. So, disclaimer, this is not my material. This is Mehlman Medical. I'm just reading. So welcome to read with me. So High Yield USMLE Review Part 1, page 3. So High Yield USMLE Review Part 1. So travel plus self-limiting watery or brown green diarrhea. This travel is diarrhea, E-Tech, HL or HS toxin. Heat labile or heat stable toxin. Okay. Bloody diarrhea plus poultry consumption, think Campylobacter jejuni or Salmonella species. Antibiotics, clindamycin. Okay, after getting antibiotics, clindamycin, beta-lactam, cephalosporin plus diarrhea, think C. diff. What is this? Diagnosis of C. diff. How do we diagnose? Okay. So with the stool AB toxin test, not stool culture. Okay. Then fever of 104 plus abdominal distension in C. diff. This is toxic megacolon. Next step is to do laparotomy. High fever of 104, abdominal distension in C. diff, toxic megacolon. Next step is to do laparotomy. Okay. Treatment of C. diff, vancomycin, not metronidazole, updated guidelines as of February 2018. Okay. Then bloody diarrhea plus travel. Yes, entamoeba histolytica. Treatment of entamoeba histolytica is metronidazole plus iodoquinol. Can give paramomycin. Okay. Close quarters or military barracks or cruise ship plus watery diarrhea, think Norwalk virus. Child less than 5 years plus watery diarrhea, rota. Yes, but if they're vaccinated, I believe it's noro. But anyway, most common is rota. Few organisms causing bloody diarrhea, Shigella. Yes, it needs a very small dose. So few organisms causing bloody diarrhea, Shigella. Then bloody diarrhea plus appendicitis-like pain, pseudoappendicitis. This is important. Yersinia enterocolitica. Bloody diarrhea plus reactive arthritis in an adult. Reactive arthritis in an adult with bloody diarrhea. Yersinia enterocolitica, Campylobacter, Shigella, and Salmonella. Okay. So Yersinia, Campylobacter, Shigella, and Salmonella. Diarrhea plus GBS syndrome. The cause is Campylobacter, yes. GBS syndrome, CSF findings, albuminocytologic dissociation. This is high yield, high protein plus normal cells. GBS syndrome diagnosis. This is important. EMG plus NCS on nerve conduction studies. Plus nerve conduction studies on NBME. Guillain-Barré syndrome diagnosis, EMG plus NCS. Cardiac ischemia plus need to evaluate ECG test. If there is cardiac ischemia and there is a need to evaluate, ECG stress test is first line. Yes. Cardiac ischemia plus abnormal baseline ECG. So if they've given us the ECG and it's abnormal, then next step will be echo stress test. Echo stress test. Need normal ECG to do ECG stress test. Okay. The next cardiac ischemia, but patient cannot exercise, then we give dobutamine. So we do, this is a chemical way to stimulate the heart, mimic exercise. So dobutamine plus ECG echo. ECG shows diffuse ST segment elevations. This is pericarditis. Pericarditis treatment is NSAID or steroid or colchicine. Central chest pain worse when supine, better when leaning forward is pericarditis. Yes. Lateral chest pain after viral infection plus increased CK. Lateral chest pain after viral infection plus increased CK is pleurodynia, intercostal muscle spasm. Then ST segment depressions in the anterior ECG leads. ST depression in the anterior is posterior MI. Okay, depression in the anterior leads is posterior MI. Okay. Then electrical alternance on ECG. This is important. Pericardial tamponade / effusion. I mean, everything's important on this page anyway. Electrical alternance on ECG is pericardial tamponade or pericardial effusion. Okay. Pulsus paradoxus, which is a drop in systolic BP more than 10 millimeter with inspiration. This is cardiac tamponade or severe asthma. Can also have pulsus paradoxus. What is pulsus paradoxus? Drop in systolic BP more than 10 with inspiration. Then we have Beck's triad, which is hypotension, muffled heart sounds, and JVD. This is seen in pericardial tamponade. Okay. Next, page 4. Treatment of tamponade. High yield pericardiocentesis or pericardial window. Tamponade, he says, do echo before pericardiocentesis if both are listed, even though it sounds wrong on 2 NBME. So do echo before pericardiocentesis if both are listed. So we can think about it like, okay, we're doing an echo and looking at the best angle to put the pericardiocentesis needle in. So do echo before pericardiocentesis if both are listed. Otherwise, we're starting with pericardiocentesis. Okay. Next, we have community-acquired pneumonia, CPP, plus bilateral chest X-ray infiltrates. Infiltrates is mycoplasma. So it looks like a community-acquired picture, but there's bilateral chest X-ray infiltrates. Usually pneumonia should have consolidation. If it has infiltrates, it's mycoplasma. CPP, community-acquired pneumonia in a lobar pattern. Right lower lobe consolidation plus dullness to percussion. This is strep pneumo. Okay. Lobar pattern, but they say interstitial in the vignette description, then go for mycoplasma, not strep pneumo. Okay. Lobar, but interstitial, think mycoplasma again. Then empiric treatment for CPP, community-acquired pneumonia, is azithromycin. Treatment for CPP is patient on antibiotics past 3 months. Fluoroquinolone over azithro. Okay, if the patient has already been on antibiotics for the past 3 months, now the treatment for CPP is fluoroquinolones over azithro. Okay. Then pneumonia in cystic fibrosis patient, less than 10 years, Staph aureus exceeds Pseudomonas. Pneumonia and cystic fibrosis more than 10 years is Pseudomonas. Yes. So if this is 10 years, less than 10 years is Staph aureus. And fake or pseudo is more than 10 years. Then pneumonia after influenza infection, you usually want Staph aureus. Okay. Pneumonia plus rabbits. Tularensis, tularemia. Yes, rabbits is tularemia. Pneumonia plus cattle, Coxiella Q fever. These are important. Pneumonia plus birds or parrots, it's Citasi, the media Citacochi or Citasi, okay. Leg swelling plus pain plus shortness of breath is pulmonary embolism caused by DVT. Treatment of PE is heparin before spiral CT. Says. Treatment of PE in pregnant women is scan, not CT, yes. Treatment of PE in someone already on warfarin, spiral CT to confirm, then give an IEVC filter. Okay. Then acid-base disturbance in pulmonary embolism is respiratory alkalosis. Alkalosis. Low CO2, high pH, low oxygen. So they're breathless, so they're gonna blow off the carbon dioxide. If they blow off the carbon dioxide, we lose the acid. So that's gonna make an alkaline pH. But they still cannot get oxygen because of the embolism. So low oxygen, normal bicarb because it's respiratory condition, too acute to change by the kidneys. So again, acid-base disturbance in PE is respiratory alkalosis. Low CO2, high pH, low O2, normal bicarb. Normal bicarb. Okay. Then acid-base disturbance in asthma is also respiratory alkalosis. Low CO2, high pH, low O2, normal bicarb. Again, it's too acute to change because I guess we're considering this an acute asthma attack. Then acid-base disturbance and aspirin toxicity in the first 20 minutes is respiratory alkalosis. Again, low CO2, high pH, normal O2, normal bicarb, too acute to change. Acid-base disturbance and aspirin toxicity after 20 minutes, it's a mixed metabolic acidosis and respiratory alkalosis. Why? Because aspirin is nothing but acetyl salicylic acid. It's an acid. So within 20 minutes, it's going to get absorbed and get into the bloodstream. So it'll increase the acid levels. It's also going to go and stimulate the respiratory center in the CNS. So increases the respiratory drive. So patient will want to blow off the carbon dioxide, leading to alkalosis. So metabolic acidosis and respiratory alkalosis after 20 minutes. So low CO2, low pH, sometimes pH can be near normal too. But anyway, low pH because acidosis, low carbon dioxide because patient is breathing rapidly, so blowing off the carbon dioxide, normal oxygen, and low bicarb. Okay. Then treatment for aspirin toxicity is bicarb. Increased excretion through urinary alkalinization. That's the idea. Treatment for TCA toxicity, sodium bicarb. Dissociates drug from myocardial sodium channels. Treatment for TCA toxicity is sodium bicarb, yes. Dissociates drug from the myocardial sodium channels. This is important. We've also seen it in first aid step on its stabilize the cardiac membranes. Normal calcium levels, okay, which is given 8.4 to 10.2. Treatment of hypercalcemia when it's 10.2 to 12. First give normal saline. 0.9% sodium chloride. Okay. Page 5, treatment of hypercalcemia when it's 12 to 14. Then give normal saline only if asymptomatic. Add bisphosphonate if symptomatic. So normal saline only. I guess my punctuation was wrong. Normal saline only if patient is asymptomatic. Add a bisphosphonate if patient is symptomatic. Then treatment of hypercalcemia when it's 14 plus. Then we're giving normal saline and bisphosphonate regardless of the symptoms. So one more time, normal calcium is 8.4 to 10.2. When it's 10.2 to 12, give normal saline. If it's between 12 to 14, then now we have to check. If the patient is asymptomatic, only give sodium chloride. I'm sorry, normal saline. If the patient is symptomatic, then add a bisphonate. If the patient has a very high calcium levels, 14 plus, probably in malignancy, then we are giving both normal saline and bisphosphonate. High calcium plus polyuria. Nephrogenic diabetes insipidus. Weird, but on NBME. High calcium plus polyuria. Okay, nephrogenic diabetes insipidus. Then high calcium plus confusion. The delirium can be caused by high calcium. Okay. If there is low calcium or potassium, which is not responsive to supplementation, the cause is low magnesium. This is important. Low calcium or potassium in alcoholic hypomagnesemia. Yes, the silly mnemonic I remember is okay, peg of alcohol, right? So peg, peg, peg. Think meg, 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 which is magnesium. So when you take lots of alcohol, it results in low magnesium. So just remember it's low. Then I was just saying what's the most common electrolyte abnormality seen in alcoholics. But here he's given low calcium or potassium in an alcoholic. Hypomagnesemia is the underlying cause. Low calcium or potassium not responsive to supplementation. The cause is low magnesium. Low calcium or potassium in alcoholic, hypomagnesemia is the cause. Next is ataxia, confusion, ophthalmoplegia, suprahial Wernicke's encephalopathy B1, retrograde amnesia plus confabulation in alcoholic is Korsakoff psychosis, Wernicke's Korsakoff syndrome, mammillary bodies. Yes. Then history of many pregnancies plus downward movement of vesico-urethral junction. Stress incontinence. Many pregnancies with downward movement of vesico-urethral junction. This is stress incontinence. Treatment of stress incontinence is pelvic floor exercises, Kegel. If it's insufficient, then we go for mid-urethral sling. Okay. Hyperactive detrusor or detrusor instability. Urge incontinence. Hyperactive detrusor or detrusor instability. Urge incontinence. Vesico-urethral instability, stress. Detrusor instability, urge. Need to run to the bathroom and sticking key in a door. This is usually the scenario in urge incontinence. Incontinence in multiple sclerosis patient or perimenopausal is urge incontinence again. Technically, MS can be mixed, but anyway. This is incontinence in MS patient or a perimenopausal patient, urge incontinence, right? Treatment of urge incontinence is oxybutynin, which is a muscarinic cholinergic antagonist, or mirabegron, beta 3 and agonist. Okay, Mira is always urgency. Mirabegron and urge incontinence. Then incontinence plus high post-void volume, usually 3 to 400 in question. Okay, the post-void residual volume is 3 to 400 ml. Normal is less than 50, then it's overflow incontinence. Incontinence in diabetes, overflow incontinence due to nephrogenic bladder. Sorry, neurogenic bladder, I don't know what I said. One more time, incontinence plus high post-void residual volume, if it's 3 to 400 in question, then it is overflow incontinence. Incontinence in diabetes. What is the type of incontinence? It's usually overflow incontinence due to neurogenic bladder. Treatment of overflow incontinence in diabetes is bethanechol, muscarinic cholinergic agonist. We had this in step 1, like post-op urinary retention or even overflow incontinence in diabetics. We are calling Bethany. Call Bethany for overflow incontinence. Then incontinence in BPH, overflow incontinence due to outlet obstruction. So BO, bladder outlet obstruction. Eventually, it becomes neurogenic bladder. Okay. Treatment for overflow incontinence in BPH, insert a catheter first, then give alpha blocker of 5-alpha reductase inhibitor, then TERP if necessary. So catheter first, relieve the urinary retention, then alpha blocker or 5-alpha reductase inhibitor, then TERP. Okay, next is exquisitely tender prostate on digital rectal exam is prostatitis. Prostatitis treatment, ciprofloxacin, which is a fluoroquinolone, mechanism of action DNA gyrase or 2-polymerase 2 inhibitor. Then costovertebral angle tenderness plus fever is pyelonephritis. CV angle tenderness plus granular casts is also pyelonephritis. Correct. It is super weird. It is not ATN. This is on 2CK beaming. Okay. CV angle tenderness plus granular casts, pyelonephritis. Okay. So whenever there's CV angle tenderness, think of pyelonephritis. Treatment of pyelonephritis is ciprofloxacin or AMPI plus Genta. Saddle anesthesia plus urinary retention is called equina syndrome. So think equina is horse, horse is saddle, right? So they go together. Saddle anesthesia, urinary retention, called equina syndrome. Versus perianal anesthesia plus urinary retention or incontinence is conus medullaris syndrome. So conus has the O, so it's just around the O, which is the anus. So perianal anesthesia plus urinary retention or incontinence is conus medullaris syndrome. Gradual onset dementia plus no sensory or motor dysfunction, Alzheimer's, gradual onset. MMSE state, mini mental state exam score is low. Patient tries to do well. That's Alzheimer's as well. MMSE exam score low, plus patient is apathetic or takes long to perform tasks, does poorly on reverse serial 7s. This is depression or pseudo dementia. Patient complains about memory loss. Normal aging, not Alzheimer's. Yeah, usually they're apathetic. They're not concerned. Usually a family member will bring the patient. But if patient is complaining, then it's usually normal aging. They lose keys, that's normal. First line treatment for Alzheimer's is donepezil, Donariva gala, which is cholinesterase inhibitors, increases cholinergic transmission and can also give galantamine or privastigmine. So Donariva went to the galas, first aid mnemonic. Then NMDA receptor, glutamate receptor antagonist used in Alzheimer's treatment is memantine. Memantine NMDA receptor, yes. Stepwise dementia or decline and or sensory motor disturbance is vascular dementia. History of hypertension in the stem plus dementia plus a sensory motor disturbance is also vascular dementia. Visual hallucinations plus Parkinson plus dementia is Lewy body, Lewy hallucinations. So plus Parkinsonism and dementia features. Then we have apathy, disinhibition plus personality change plus dementia. Disinhibition is very important for frontal. Frontal lobe is pretty much responsible for personalities. So disinhibition, personality, hyperorality, all those things, frontal lobe. So apathy, disinhibition plus personality change plus dementia as well is frontotemporal dementia, also known as Pick disease. I should remember that Pick disease is the other name. Next is urinary incontinence plus ataxia plus CNS dysfunction, wet, wacky, wobbly, normal pressure hydrocephalus, wet, wobbly, wacky, wet, wobbly, wacky plus Parkinsonism is still NPH. Parkinsonism in a young patient, Wilson's disease, till proven otherwise. Nice. Parkinsonism in a young patient is Wilson's disease until proven otherwise. Parkinsonism is an older patient is Parkinson's, right? Parkinsonism plus axial dystonia. Axial dystonia. Right, this is the weird wording that they use. Axial, that is the, I guess, trunk movement. Axial dystonia is progressive supranuclear palsy. Then treatment of UTI, TMP, SMX, or nitrofurantoin. Yes, treatment of cystitis, nitrofurantoin. No need not be pregnant. Yeah, it's safe in the second trimester, but here he says even if in a non-pregnant patient, treatment of cystitis is still nitrofurantoin. Weight or tip position in the kid. Yes, this is upper brachial plexus injury, C5, C6, abduction palsy. Claw hand, lower brachial plexus, C81, Klumpke's. Yeah, we've studied this in step 1. So, weighter tip is abduction. Claw hand is Klumpke's. So, CLKL, right? Claw hand is Klumpke's. They're not going to say weighter's tip. You have to identify it based on the physical examination. Then pronated arm plus wrist drop. Wrist drop is radial nerve injury. Mid-shaft fracture of humerus, radial nerve injury. Supracondylar fracture of humerus, median nerve injury. Supracondylar fracture of humerus, yes. And usually in step 1, we had medial displacement, that's median nerve. Surgical neck of humerus fracture is axillary nerve, leading to axillary nerve injury, okay. Medial epicondylar injury, ulnar nerve injury. Supracondylar fracture of humerus, median nerve. Surgical neck, axillary. Medial epicondyle, ulnar nerve injury. Then we have weakened biceps plus loss of sensation of lateral forearm. Weak biceps is musculocutaneous nerve injury. Weakened biceps, that's muscle that everyone likes to show off. So weakened biceps plus loss of sensation of lateral forearm is musculocutaneous nerve injury. Paresthesias plus pain following burn or casting. Compartment syndrome. Paresthesias plus pain following a burn, okay, because fluid will fill up, or a casting for some fracture. That is compartment syndrome, okay. Next, compartment syndrome diagnosis, measure compartment pressure. Compartment syndrome treatment, fasciotomy of uncast. Fasciotomy or like uncast, like remove the cast, I believe. Then guy lifts a heavy box, leads to severe lower back pain plus muscle spasm, no radiculopathy. It's a lumbosacral strain only. Usually there'll be paraspinal tetanus. We don't need to do any imaging, just NSAIDs and observe, like painkillers. So then lumbosacral strain diagnosis. Yes, he says do not X-ray. Lumbosacral strain treatment, NSAIDs plus exercise as tolerated. Bed rest is the wrong answer. Yes. MSK, bed rest is never the answer. It's usually normal activity as tolerated. Next question. Guy lifts a heavy box, severe lower back pain, plus radiculopathy. Herniated disc. Yeah, if there is radiculopathy, which means the nerve, there's radiating pain, severe pain, radiating pain, neurosensory loss is there, then it's a herniated disc, and then we are going to do X-ray. Point tenderness over vertebra in old women. Point tenderness is keyword, osteoporosis, compression fracture. Point tenderness over a vertebra in a younger patient who's taking steroids, also osteoporosis, also compression fracture. Right. Point tenderness over a vertebra in a patient with autoimmune disease. So they're not going to tell us directly patient is taking steroids. So autoimmune disease, we have to recognize that patient is on steroids. And osteoporosis, compression fracture again. Point tenderness in an IV drug user, epidural abscess. Step off, keyword of one vertebra relative to another is spondylolisthesis. Listhesis is slippage. Back pain worse in the morning and gets better throughout the day in a male 20s to 40s. This is ankylosing spondylitis. I think there was a CMS form where there was a 8 or a 17-year-old with sacroiliitis or a younger patient with ankylosing. It's weird but possible, I believe so. Anyway, so back pain worse in the morning and gets better throughout the day in a male, 20s to 40s is ankylosing spondylitis. Bamboo spine, ankylosing spondylitis. Diagnosis of AS, how do we do? X-ray of sacroiliac joints. I think they've given us an X-ray also of this. We're supposed to recognize the bamboo spine. Back pain worse when standing or walking for long periods of time is lumbar spinal stenosis. Worse when standing or walking for long periods is lumbar spinal stenosis. Radiculopathy down an arm is cervical disc herniation. Bilateral paresthesias in arms. In a rheumatoid arthritis patient, bilateral. Think atlantoaxial subluxation. This is very high rheumatoid patient. Bilateral paresthesias in the arms. In rheumatoid arthritis patient, what do we do? MR of spine to diagnose atlantoaxial subluxation. Prior to surgery in a rheumatoid arthritis patient, cervical CT or flexion extension X-rays of cervical spine to check for atlantoaxial subluxation. This is very, I've made this mistake. This is very subtly, patient is going to go for like cholecystitis surgery or some random GI unrelated to the rheumatoid arthritis. But if you notice subtly, they'll say past history is rheumatoid patient. So the next step will be cervical CT or flexion extension of X-ray cervical spine. Why? To check for atlantoaxial subluxation, which is very common in RA patients. Then back pain in elderly patient with hypercalcemia, multiple myeloma or metastasis. Back pain in elderly patient with hypercalcemia, it's either multiple myeloma or METs. So multiple myeloma, we look for the CRAB findings. So hypercalcemia, renal, anemia, bone pain. So this calcium, think multiple myeloma or METs. Okay. Back pain in a patient with history of other type of cancer. Also think METs, right? Suspected spinal METs, do an MRI. METs to long bones and prostate cancer are osteoblastic, diagnosed with a bone scan. For spine, do an MRI. Oh, interesting. So METs to the long bones and prostate cancer, there are osteoblastic lesions. So they're diagnosed with a bone scan. If it's a spine only, we do MRI. So push and blast. Prostate, small cell, and Hodgkin's is blastic lesions, whereas L, M, N, O, R are lytic lesions. So L for lytic, M for malignant melanoma, and I forget. NO is non-Hodgkin's, non-small cell lung cancer, R is renal. What is the other M? Multiple myeloma. Okay, yeah. Multiple myeloma and malignant melanoma. Okay, cool. So back to this. Mets to long bones and prostate cancer is osteoblastic, diagnosed with bone scan, spine to MRI. High hemoglobin, plus or minus pruritus after shower, plus or minus a plethora, plus or minus sphenomegaly, think polycythemia vera. Yes. Aquagenic pruritus. So it gets worse after shower, polycythemia vera. High hemoglobin plus low EPO, also polycythemia vera. Pruritus after shower is causes basophilia. High hemoglobin plus lung disease with low PO2, secondary polycythemia because of high EPO. So this low PO2 will stimulate the lungs to produce more and more EPO. That will lead to secondary polycythemia. Okay. Next, page 8. Polycythemia plus hypercalcemia plus smoker plus red urine is RCC, paraneoplastic EPO plus PTHRP. Blurry vision or Raynaud or pain in fingers and or headache is hyperviscosity syndrome. Polycythemia plus hypercalcemia plus smoker plus red urine. Think RCC. This polycythemia is due to paraneoplastic EPO. This PTHRP is hypercalcemia. I think that first statement was PEAR, which is the paraneoplastic. EPO, ACTH, PTHRP in RCC, I guess. I think so. Let me confirm. Oh, R is renin. So P for PTHRP, E for ectopic EPO production, A is ACTH, R is renin. Okay. Then blurry vision or Raynaud or pain in fingers or headache is also because of hyperviscosity syndrome. Hyperviscosity syndrome can also be seen in Waldenstrom's macroglobulinemia or polycythemia. Next is hereditary spherocytosis. It is autosomal dominant, ankyrospectrin or band protein deficiency. Treat with splenectomy. Treatment for ITP is steroids, then IVIG, then splenectomy. So for ITP, first give glucocorticoids or steroids, then IVIG, or let's say steroids, then IVIG, and then splenectomy. ITP cis. Okay. Then treatment for hereditary hemochromatosis is serial phlebotomy. Yes. Treatment for secondary hemochromatosis is for transfusion siderosis. Then we'll give chelation therapy, which is deferoxamine. Yes, this is important. It's a difference. If it's hereditary, then we remove the blood with serial phlebotomy. If it's secondary, then which is due to getting transfusions, here we have to do chelation therapy with deferoxamine. Then viral infection plus tinnitus plus vertigo plus or minus neurosensory hearing loss is labyrinthitis. Viral infection plus tinnitus plus vertigo plus or minus neurosensory hearing loss is labyrinthitis. Viral infection plus vertigo is vestibular neuritis. So the difference is the tinnitus and maybe plus or minus hearing loss. Okay. Then treatment for multiple sclerosis flares is IV steroids, IV methylprednisolone. This has been tested on NBMEs. Given to MS patients between flares is interferon beta. So in flare, give steroids. Between flares, interferon beta. I think we also have a question, glatiramer, and all the other disease-modifying agents between flares. Then treatment for spasticity in MS is baclofen, which is a GABA B receptor agonist. Spasticity, yeah, sorry, where did it go? Spasticity in MS is baclofen, GABA B. Incontinence in MS is urge because of hyperactive detrusor. This we saw it earlier. Yes, new onset murmur plus a fever is endocarditis until proven otherwise. New onset murmur plus fever is endocarditis until proven otherwise. Empiric treatment for endocarditis is vancomycin or ampicillin sulbactam plus gentamicin. So endocarditis is either vanco or ampigenta, sorry, ampicillin sulbactam plus genta. Okay. Then beta-lactam naphthalin or cephalosporin plus rash plus renal issue is AI and acute interstitial nephritis. Interstitial nephritis will also have WPCs in the urine, which are eosinophils. Yes. Fixed splitting of AS2 is ASD. Holosystolic murmur at the left sternal border plus either parasternal heave or palpable thrill is VSD. One more time. Holosystolic murmur at the left sternal border plus either a parasternal heave or a palpable thrill is VSD. Yes. Holosystolic murmur at the left sternal border plus a diastolic rumble is also VSD. To and fro murmur is a PDA. So they can call it to and fro murmur. They call it pansystolic, pandiastolic murmur. Or as we know it, excuse me, continuous machine-like murmur is also PDA. Congenital rubella syndrome also leads to PDA. Heart problem in neonate of mom with SLE. This is important. Congenital third-degree heart block. Heart problem in Williams syndrome. Supravalvular aortic stenosis. Williams syndrome. Supravalvular aortic stenosis. Bicuspid aortic valve, aortic stenosis. Yeah, if it has only two cusps, it's going to get stenosed. So bicuspid aortic valve, aortic stenosis. Mid-systolic crescendo decrescendo murmur, which gets worse with Valsalva, is Hokum. Mid-systolic crescendo decrescendo murmur with no change or softens with Valsalva is aortic stenosis. Next is myxomatous degeneration of mitral valve, MVP. Myxomatous degeneration of mitral valve will lead to mitral valve prolapse. Marfan's or Ehlers-Danlos syndrome is MVP or aortic regurg. Rheumatic heart disease acutely. Onset of group A strep infection is MR. Later on, years after rheumatic heart disease is MS. Mid-systolic click is MVP. So Dr. Ryan says pro click and I guess steno snap. Anyway, so mid-systolic click is for MVP. Then late peaking systolic murmur with ejection click. Another way they describe aortic stenosis. This is also important. The more worse the stenosis, the later it gets. So late peaking systolic murmur with ejection click. Then bounding pulses plus massively wide pulse pressure. Aortic regurg. Wide pulse pressure is aortic regurg. Brisk upstroke plus precipitous downstroke of pulse is also aortic regurg. So different words the way they describe, I guess. Bounding pulses, massively wide pulse pressure. Brisk upstroke plus precipitous downward stroke. So upstroke, downstroke. Aortic regurg. The SAD, SAD of aortic stenosis, syncope, angina, dyspnea. Dyspnea in second trimester of pregnancy. It could be due to mitral stenosis. Dyspnea in late in pregnancy. So second trimester is stenosis. Later on, it is cardiomyopathy. Then screening at age 50 is mammogram every 2 years. Plus colonoscopy every 10 years. I think this has changed. This time in October 2025. I believe we started a bit earlier with shared decision making. I'm not wrong. Anyway, screening at age 50 is mammogram every 2 years plus colonoscopy every 10 years. Colon cancer in first degree relative, sibling or parent. Started age 40 or 10 years before the diagnosis in the relative, whichever is earlier, and do every 5 years. Yes. Breast imaging is performed. Ultrasound only under age 30. Over age 30, do mammo plus or minus ultrasound. Anuria, which is no urine output. After a mole of catheter, that means there's an acute urethral obstruction. Anuria, no urine output after removal of a catheter, acute urethral obstruction. Okay. Then contrast-induced nephropathy, how do we prevent? Give saline hydration beforehand. Bun-creat ratio more than 20. This is pre-renal hypovolemia. Yeah, pre-renal azotemia. So due to hypovolemia, and it can lead to heart failure. Or due to heart failure, I guess. Bun-creat ratio less than 20, it's not pre-renal. 15 to 20 for post-renal. Less than 15 for intra-renal is wrong on CK and BMAs. One more time, if bun-creat ratio is more than 20, then we notice pre-renal azotemia due to hypovolemia from heart failure. If bun-creat ratio is less than 20, it's not pre-renal. "15 to 20 for post-renal and less than 15 for intra-renal is wrong on 2CK and BME. So I thought on step 1 first aid we said more than 20 is pre-renal azotemia. Less than 15 is intrinsic renal failure. Post-renal varies. Less than 15 for intrarenal is wrong on 2CK and BMEs. Okay, so I guess we have to take it with a pinch of salt. I'm not sure what he means. Bun-creat ratio less than 20 is not pre-renal. So basically it's just ruling out pre-renal for us. 15 to 20 for post-renal and less than 15 for intrarenal is wrong on 2CK and BMEs. Okay. Blood loss plus oliguria is ATN, acute tubular necrosis. Blood loss plus obstetric catastrophe is diffuse cortical necrosis. Blood loss plus obstetric catastrophe is diffuse cortical necrosis. Sickle cell plus nephrotic syndrome is sickle cell, yes, is FSGS. Sickle cell plus red urine is renal papillary necrosis. Okay, sickle plus nephrotic, sickle plus red. Then 2 plus blood in the urine, but 0 to 4 RBCs on per hyperfield on light microscopy. False positive blood on dipstick, myoglobinuria, this is rhabdomyolysis. 2 plus blood in urine, but only 0 to 4 RBCs. So very low RBCs, this is almost normal RBCs. 0 to 5 RBCs can be there normally also. This is false positive blood on dipstick. It's actually due to myoglobinuria. The blood is due to myoglobin, due to secondary to rhabdomyolysis. Okay. Pleural or subdiaphragmatic plaques is asbestosis. Yes. Preferred antibiotic in sepsis is ceftriaxone. Sepsis treatment in young children is cefotaxime. Treatment for spontaneous bacterial peritonitis is ceftriaxone. Cirrhosis or recent peritoneal dialysis or nephrotic syndrome plus fever plus abdominal pain. Recent peritoneal dialysis or cirrhosis. So there's fluid that gets infected in spontaneous bacterial peritonitis. Yes. For SBP diagnosis, we need to do paracentesis. which is peritoneal aspiration. Do not confuse it with pericardiocentesis. So paracentesis, then do gram stain. Look for more than 250 WBCs per high power field. Okay, next, dysphagia to solids and liquids at the same time to start. So solids and liquids at the same time. Says it's a neurogenic cause. So think achalasia. Okay. So dysphagia to solids that progresses to solids and liquids is esophageal cancer. Halitosis plus or minus gurgling sound when swallowing, plus or minus regurgitation of the undigested food is Zenker's. Zenker's plus achalasia, initial diagnostic mortality is barium swallow high yield. After barium swallow is done and it shows bird beak's appearance, then we do manometry to confirm diagnosis of achalasia. Okay. Hmm. Patient with history of GERD plus dysphagia, straight to endoscopy to rule out cancer. GERD plus dysphagia, directly to endoscopy. Hmm. Diabetic patient with new onset GERD, diabetic gastroparesis. Diabetic patient with new onset GERD. This is diabetic gastroparesis. Okay. Diabetic patient with new onset GERD, give metoclopramide, not PPI. So this will help with motility. We're not going to give PPI. Okay. This is nice. Diabetic gastroparesis before giving med. Endoscopy first to rule out physical obstruction. If it's endoscopy negative for diabetic gastroparesis, then next is to do gastric emptying scintigraphy. Okay. So again, patient history of GERD plus dysphagia, start straight to endoscopy to rule out cancer. Diabetic, these three are diabetics. Actually, all four. Hmm. Diabetic patient with new onset GERD, we're thinking of diabetic gastroparesis. What do we do? Before we give meds, we should do endoscopy first to rule out physical obstruction. If endoscopy is negative, then do a gastric emptying scintigraphy. If they've given medication in the list, we pick metoclopramide. So in order of what we do, if for new onset GERD, suspect diabetic gastroparesis diagnosis. Next best step is endoscopy first. Confirmatory test, gastric emptying scintigraphy. Medical therapy, metoclopramide. Okay. Next, bulimia nervosa or anorexia. Never give bupropion, seizure risk. Electrolyte abnormality in anorexia is hypokalemia. Hmm. Most common cause of death in anorexia is arrhythmia from hypokalemia. Okay, refeeding syndrome, worry about hypophosphatemia. Treatment of anorexia plus depression is mirtazapine, alpha 2 agonist. It stimulates appetite and causes weight gain, so makes sense. Next is amenorrhea in anorexia. Low FSH plus low estrogen, hypogonadotropic. Yeah, hypogonadotropic, hypogonadism. So they have low FSH and low estrogen. Next, premature ovarian failure plus Turner syndrome plus menopause. High FSH, low inhibin, low estrogen. So Turner syndrome has streak ovaries and premature ovarian failure. So premature menopause. So actually all these three conditions, POI or POF, Turner's and menopause, all these three have high FSH, low inhibin, low estrogen. Could easily be a narrow question. Okay. Next, cholelithiasis, diagnosed with abdominal ultrasound, fat 40 female fertile. Biliary colic plus fever, it is cholecystitis. Treatment of cholelithiasis and cholecystitis is cholecystectomy. Patient does not want surgery or is pregnant, then we will consider ursodeoxycholic acid, ursodiol. Abdominal ultrasound, negative in suspected cholecystitis. So the only time HIDA scan is usually an answer is when ultrasound is negative, but clinical suspicion is still high for cholecystitis. So then we do HIDA scan. Gallbladder does not light up on HIDA scan. That confirms cholecystitis. So we should remember this. It doesn't light up on HIDA scan. It confirms cholecystitis. Cholelithiasis in pregnancy. Why? Estrogen upregulates HMG-CoA reductase and progesterone slows biliary peristalsis. So this leads to gallstones. Then trichotillomania is eating one's hair plus GI symptoms. The reason is a gastric bezoar or a hair ball. History of surgery plus high-pitched bowel sounds or acute onset abdominal symptoms. This is small bowel obstruction. History of surgery, high-pitched bowel sounds or acute onset abdominal symptoms, small bowel obstruction. So this surgery caused some stricture and that's causing obstruction. Okay, I guess this is halfway point. Let me see, 10. Nine and a half pages. So let me take a 5-minute break and come back. Okay, be right back. Okay, we'll continue. So we said trichotillomania, eating one's hair plus GI symptoms, gastric bezoar, hair ball, history of surgery plus high-pitched bowel sounds or acute onset abdominal symptoms will lead to a small bowel obstruction. Next, page 11. Renal failure plus friction rub over the chest. Uremic pericarditis, do hemodialysis. Uremia is an indication for hemodialysis. Renal failure, so that will lead to uremia, and uremia will cause pericarditis, leading to the friction rub. Okay, high leukocytes plus high leukocyte ALP. Leukocyte ALP is leukemoid reaction. High leukocytes plus low lab score is CML. Alkaline phosphatase, right, inside the leukocyte. So anytime there's inflammation, this will pour out and increase. So leukemoid, high ALP score, or this is nothing but LAP. And high leukocytes plus low leukocyte ALP is CML. Metamyelocytes plus myelocytes and splenomegaly is CML. Treatment of CML is imatinib, causes fluid retention and edema. What is this? Tyrosine kinase inhibitor. Oops, am I sharing my screen? Yes. Okay. Where was I? Imatinib causes fluid retention and edema. Smudge cells plus autoimmune hemolytic anemia is CLL. Mnemonic crushed little lymphocytes, which appear as smudge cells. Excuse me. Then we have OR rods AML, composed of myeloperoxidase. Okay, so OR rods AML, composed of myeloperoxidase. Treatment of AML can lead to DIC. Why? Because OR rod released into blood. And that's a lot of myeloperoxidase. This can trigger DIC. Okay, wow. I don't remember this. Kid with lymphocytes, ALL, or pertussis. Weird because it's bacterial. Yes, pertussis is bacterial, but it causes high lymphocytes. But lymphocytes are often more than 30K. ALL, adults less likely, so it's usually in kids. Or pertussis, because why is this weird? Because it's bacterial, but it's causing lymphocytes, which is usually the viral. Dry cough in winter, cough variant asthma. 1/3 of asthmatics only have cough. Young African American women plus dry cough plus normal chest X-ray. Asthma, not sarcoidosis. Dry cough with normal chest X-ray. Because for sarcoid, we're looking at hilar enlargement. Okay, so even African American woman with a dry cough, with the normal chest X-ray, think asthma. Young African American woman plus dry cough plus nodularity on chest X-ray, then think sarcoidosis, which is non-Chiari granulomas. Then electrolyte disturbance in sarcoid is hypercalcemia, low PTH. So this is the granulomatous conversion leading to hypercalcemia. With hypercalcemia, will go and feedback inhibit PTH, so low PTH and high calcium. Okay. Hypercalcemia and sarcoid, why? So here we go. Epithelioid activated macrophages produce 1-alpha hydroxylase, thereby activating vitamin D3. Then increased calcium in sarcoid means decreased calcium in feces, because D3 increases small bowel absorption. Increased calcium in sarcoid means decreased calcium in feces, because D3 increase small bowel absorption. Okay. Treatment for sarcoid is steroids. Outpatient treatment of asthma is SABA, then low dose ICS, then maximized dose of ICS, then LABA. Then use any number of drugs, mast cell stabilizers, anti-leukotriene, etc. Then oral steroids is last resort. Kids with asthma on SABA inhaler, not effective. Next best step. Inhale corticosteroid, fluticasone. In kid with asthma on SABA inhaler, plus most effective way to decrease recurrence is oral steroids. It's not the next best step, but certainly the most effective. Okay. Then 40s male with hematuria plus hemoptysis is Goodpasture syndrome. 40s male with hematuria, yeah. If the like kidney plus the lung, then it's Goodpasture's. Antibodies in Goodpasture is anti-GBM, which is anti-collagen 4 antibodies. Diagnosis of Goodpasture is antibodies first, but confirmatory is renal biopsy. What does it show? Linear immunofluorescence. Okay, next, hematuria plus hemoptysis plus headitis. Oh, nice. I like the way I said that. So hematuria, kidney, plus hemoptysis, lung, plus head. So headitis, either mastoiditis, sinusitis, otitis, nasal septal perforation. This is Wegener's. New name for Wegener is granulomatosis with polyangiitis. How do we diagnose Wegener? CNK, which is also known as anti-PR3, anti-proteinase 3. Then asthma plus eosinophilia is Churg-Strauss. New name for Churg-Strauss is eosinophilic granulomatosis with polyangiitis. So this is GPA, this is EGPA, Churg-Strauss. How do we diagnose Churg-Strauss? PNK, anti-MPO, anti-myeloperoxidase. Hematuria in isolation plus PNK in serum is microscopic polyangiitis. Hematuria in isolation plus PNK in serum. This is microscopic polyangiitis. Severe renal disease in Wegener's or Goodpasture's or MP. So all these above three, the three that we saw, Wegener's, Goodpasture, or MP. Then think rapidly progressive glomerulonephritis, crescentic. Renal disease in Wegener's, Goodpasture's, or MP. Then we have high ALP plus high direct bilirubin plus high amylase or lipase. Gallstone pancreatitis. Also equals choledocholithiasis. Choledoco, this is gall, like the duct as a stone. So one more time, high alkaline ALP, high direct bilirubin, high amylase or lipase. This indicates gallstone pancreatitis or choledocholithiasis. Then next is high ALP, high direct bilirubin, high amylase or lipase, plus a remote history of cholecystectomy. The gallbladder is not there. So now this is sphincter of Oddi dysfunction. Cannot be a stone because the gallbladder was removed ages ago. Sphincter of Oddi dysfunction. So we've already removed the gallbladder now. Next, high LP plus high direct bilirubin plus normal amylase or lipase in someone with a recent cholecystectomy, then choledocholithiasis. retained stone in the cystic duct that descended but not distal to the pancreatic duct entry point. So recent, one more time, high ALP, high direct bili. So there's no way for the bilirubin to go into the intestine. So it's increased. Plus normal amylase or lipase in someone with a recent cholecystectomy is choledocholithesis. So the stone is stuck in the duct that descended but not distal to the pancreatic duct. Okay. Diagnosis and treatment of choledocholithesis is ERCP. Then next is high ALP plus high direct bili plus normal amylase or lipase in someone with remote cholecystectomy. Pancreatic cancer. What was different between here and here? Okay, this was recent. This was remote, so far away in the past history. So if it was recent, then we think that choledocholithesis, basically the stone escaped into the duct. But if it's a remote history, now this is pancreatic cancer. Okay. How do we diagnose pancreatic cancer? CT abdomen with contrast. High ALP plus high direct bili plus normal amylase or lipase in someone with a remote cholecystectomy plus CT is also negative. So we have next step now. CT is done to look for pancreatic cancer, but that's negative. Then cholangiocarcinoma. Bile duct se cancer. Okay. Next, high ALP plus high direct bili plus normal amylase or lipase plus diffuse pruritus plus high cholesterol is PBC, primary biliary cirrhosis. Nice. High ALP plus high direct bili plus normal amylase or lipase plus autoimmune disease, either in patient or the family, also think PBC. Diagnosis of PBC is anti-mitochondrial antibodies. Next best step is the next best step. Antibodies is the next best step, okay. But liver biopsy is confirmatory. So we have to be careful. What are they asking? If it's the next best step, then it is antibodies. If it's confirmatory, then it is liver biopsy. Recent cholecystectomy plus fever plus abdominal pain, post-op bile leak. High ALP plus high direct bilirubin plus normal amylase or lipase plus CT shows cystic lesion in bile duct. This is a choledochal cyst. CT is showing cystic lesion in the bile duct. This is a choledochal cyst. Do a simple excision of cyst. Cholangiocarcinoma is not cystic. Plus CT can be negative. So CT negative, so cholangiocarcinoma. So if it shows a cyst, which is unlikely to be cholangiocarcinoma, so then we diagnose it as choledochal cyst. Then imaging to view the liver or pancreas is CT with contrast. For liver or pancreas is CT with contrast. Okay. Imaging to view the gallbladder is ultrasound. Imaging to view gallbladder and suspected cholecystitis. Only if ultrasound is negative is HIDA scan. Yes, we saw this. Imaging to view bile ducts is ERCP or MRCP. Choose ERCP is if more than MRCP if both are listed. Then teenage girl with history of cutaneous candida infection since childhood. This is chronic mucocutaneous candidiasis. Most common answers T cell dysfunction. Impaired cell-mediated immunity on USMLE. Bacterial plus fungal plus protozoan plus viral infection plus birth is SCID. Okay, now we've moved to immunology questions. Then bacterial infections since age 6 months is Bruton's. Bacterial infections only since birth. Okay, bacterial infections only since birth. They don't have any other viral or other infections. It's Bruton. Rare as hell to say from birth, but it's on the new 2CK MDMA. Hmm. SCID X-linked recessive variant is common gamma chain mutation, IL-2 receptor deficiency. SCID autosomal recessive variant is ADA deficiency. For Bruton's, the mechanism is tyrosine kinase mutation. Okay, and the next we have hyper IgM syndrome, deficiency of CD40 ligand on T cell. Can't activate CD40 on B cell to induce isotype class switching. Once again, what is hyper IgM syndrome? This is deficiency of CD40 ligand on T cell. If this is missing, it cannot activate CD40 on B cell to induce the isotype class switching. Okay. Next, we have greasy scalp plus itchy papules. In an adult, it's seborrheic dermatitis. Treatment for seborrheic dermatitis is given azole or a selenium shampoo. This is nothing but commonly layman term is dandruff. Given azole or a selenium shampoo, topical. Treatment for tinea capitis is oral griseofulvin for the patient only. They'll ask for family members, what do we do? No, it's only for the patient. How to decrease risk of tinea capitis? Avoidance of sharing of hats and all those things. Hats and towels and stuff we don't share. Treatment of onychomycosis is oral. So for capitis and nail, it is oral treatment. For tinea pedis, that is the foot, topical terbinafine or topical azole. For tinea corporis, the ringworm, topical azole, clotrimazole or miconazole. Treatment of cutaneous candida, oral azole. For oropharyngeal candida, nystatin mouthwash. For esophageal candidiasis, oral azole, not nystatin mouthwash. Treatment of vaginal candidiasis, topical nystatin before trying oral azole. Odynophagia, painful swelling in an immunocompromised patients. It is in esophageal candidiasis until proven otherwise. Then CNS fungal infection or fungemia with rigors on chills, give Am4B. Cryptococcal meningitis is Am4B plus flucytosine, then do fluconazole taper. Simple fungal pneumonia, give fluconazole. Sporothrix shenkai, rose thorn plus finger papule, give itraconazole. Hypopigmentation on the upper back or trunk, which is tinea versicolor, Malassezia furfur. Treatment of tinea is topical selenium. Most common cause of impetigo, Staph aureus now exceeds strep pyogenes. Treatment of impetigo is topical mupirocin. Beefy red, well-demarcated skin plaque is erysipelas. But I think we've seen a question where they say well-demarcated, but turns out it was cellulitis by group A strep. Anyway, it was this other choice was not there, so it was okay. Anyway, back to this. So beefy red, well-demarcated skin plaques is erysipelas. Most common cause of erysipelas is group A strep pyogenes more than Staph aureus. Group A strep pyogenes more than Staph aureus. So for impetigo, Staph aureus precedes. For erysipelas, gas group A strep. Next, page 14. More diffuse pink lesion. Okay, so we're differentiating erysipelas from cellulitis. Most common cause of erysipelas is a group A strep, more than Staph aureus. More diffuse pink skin lesion plus tenderness and fever is cellulitis. Most common cause of cellulitis is again Staph aureus exceeds strep pyogenes for impetigo. So for impetigo and cellulitis, Staph aureus is most common. For erysipelas, it is group A strep, which is strep pyogenes. Then treatment of erysipelas plus cellulitis. Oral dicloxacillin or oral cephalexin. Erysipelas, which is group A strep, or cellulitis, which is Staph aureus, we are giving oral dicloxacillin or oral cephalexin. Then white complex tachycardia, ventricular tachycardia. Okay, now I'm moving to arrhythmias. White complex tachycardia, ventricular tachycardia. Narrow complex tachycardia, SVT. Treatment of SVT is first we do vagal or carotid massage first. If it doesn't work, then adenosine. Treatment of VT is antiarrhythmics like amiodarone. Treatment of SVT or VT in the setting of coma or unconsciousness, direct current countershock, which makes sense. Patient is unstable, patient is unconscious, directly go for current countershock. Treatment of first degree heart block or second degree Mobitz 1. So anytime there's first, which is 1, or um, Mobitz type 1, second degree, but Mobitz type 1. So again, we will observe. If it's Mobitz type 2 or a third degree heart block, then we need a pacemaker. Then first degree heart block, PR interval is more than 200 milliseconds. Mobitz 1, so it's just a prolonged PR interval, more than 200 milliseconds. Mobitz 1 is gradually prolonging PR interval before a QRS drops. Mobitz 2, no gradual prolongation, but QRS randomly drops. Third degree, heart rate is super low at 30 to 40. There's no relation between P waves and QRS complexes. Infective causes of third degree. Okay, infective causes of third degree heart block. Third degree, so we have three things. We have Lyme, we have lupus, and we have diphtheria. Congenital lupus, okay, that's why it's infective. Lyme disease, congenital lupus, and diphtheria. Because in congenital lupus, those antibodies from the mother will pass through and go to the baby and attack the baby's like heart. So it causes third degree heart block. Then next is give killed IM influenza vaccine when? Every year in fall or winter only, start from 6 months of age. Killed IM influenza vaccine is safe in pregnancy. Yes, it's killed, so it's safe and give anytime to pregnant women. Live attenuated intranasal influenza vaccine guidelines only give age 2 to 49 non-pregnant, non-immunocompromised persons. So the live version of the intranasal influenza vaccine, 2 to 49, non-pregnant, non-immunocompromised. Vaccines at age 2, 4, 6 months. It's okay, now we move to vaccines. Hep B, polio, salk version. No more PCV 13. I guess this is no longer given in the US. We have PCV 15. DPT, HIB, rotavirus. Also give Hep B at birth. So 2, 4, 6. Hmm. Wasn't the mnemonic B, Dr. Hep? So B for Hep B, D for DPT, R for Rota. Um, so the one is Hep B, one is H influenza type B, and the P, I guess, is for polio. So Hep B, D for DPT, Rota, H influenza type B, polio, and pneumococcal. Then HPV vaccine when? Age 9 to 45. 9 to 45. Yes, 9 to 45. Yes. After a point, I guess it's shared decision making. So HPV vaccine can be given between 9 to 45. Mom's Hep B status is unknown. If mom's Hep B status is unknown, give the neonatal Hep B vaccine. Only give immunoglobulin if mom comes back positive. MMR, first dose at 12 15 months, second dose at age 4 to 6 years. MMR, first dose at 12 to 15. Yes, it's a live vaccine, so we give it at 1 year. Second dose at age 4 to 6 years. Okay. Varicella, again, live vaccine, so one dose between 12 to 18 months. Age 65 or older. This is updated now. The age is also reduced. I think we give PCV 15. Followed by PPSV 23, 6 to 12 months later. If we give PCV 20, then we don't need to follow it up with anything else. B's bus, yeah. I think the age changed to 45. Check. So less than 65, one dose of PCV 20 or sequential PCV 15 plus PPSV 23. I think even newer on Ambos, the age changed to much younger, not 65 anymore. Double check. 1 second. Where did I see it? Okay, here it is. Yeah, 50 years. more than 50 years, more than equal to 50 years, no prior dose of PCV 15 or 20 or 21, or unknown vaccine status. What do? We give one dose of PCV 20 or PCV 21, or one dose of PCV 15, followed by 1 year later a dose of PPST 23. So अगर 20 या 21, like 20 or 21 if we give, it's one dose is sufficient. If we give PCV 15, then we need to follow it up 1 year later with a PPSV 23. Yeah, we're starting at 50 years now, more than equal to 50 years. Yeah, and PCV 13 is no longer available in the US since April 2024. Okay. All right. So that was that. Then next one we have asplenia or sickle cell. Okay, here also it says PCV 13 plus PCV 23. I guess again this will be PCV 15 followed by 23. Yeah. 15 or 20 followed by PPSV 23, but we no longer use PCV 13. Then circular lesion in pancreas seen in pancreatitis, which is a pseudo abscess. Answers ERCP to drain internally. I've forgotten this pseudo abscess. And we will do ERCP to drain internally. Then bullous changes on chest X-ray or expanded lungs and hyperlucency. This is emphysema. Then centri assigner emphysema, central smokers. Pan assigner is alpha-1 antitrypsin deficiency. Young adult plus non-smoker has emphysema. Relative died of hepatic cirrhosis. So liver and lung, think alpha-1 antitrypsin deficiency with family history. Then Crest syndrome, what's the lung pathology? It can cause pulmonary fibrosis leading to pulmonary hypertension. Restrictive lung disease, there is normal, okay, lung. Restrictive lung disease, how do they present? Normal or increased FEV1 FVC. Obstructive lung disease, decreased FEV1 FVC ratio. So if it is decreased FEV1 FVC, it's always obstructive. If it is normal or increased, it's restrictive. Why is FEV1 FVC ratio normal or high and restrictive? It's because radial traction on outside of the airways is sticky. So that keeps the airways from closing. Then apex to base lung changes when sitting to standing. Apex to base lung changes when sitting to standing. Both ventilation and perfusion increase from apex to base. Interesting. Apex to base lung changes when sitting to standing. From when sitting or standing. So both apex to base, sorry, both ventilation and perfusion, it's better apex, higher at the apex and lower at the base. Okay. And then most common cause of otitis media is strep pneumo. Treatment of otitis media is oral amoxicillin only. Treatment of recurrent otitis media, amoxiclav. When to do tympanostomy tube? 3 or more otitis media in 6 months, or 4 or more in a year, then we'll put a tube. Most common cause of otitis externa. Externa is Pseudomonas. Pseudo people keep them outside. External. Treatment of otitis externa, topical ciprofloxacin plus hydrocortisone drops. Prevention of OE in someone with constant water exposure, like a crew team or like a swimmer. Alcohol acetic acid drops. This was an MBA question. Treatment of ear wax buildup, carbamide peroxide drops. Carbamide peroxide drops. Then low hematocrit plus low MCV plus low transferrin plus low TIBC plus transferrin saturation is normal or low. Once again, what is this? Low hematocrit, low MCV, low transferrin, low TIBC. So far it sounded like iron deficiency anemia, but transferrin, which is a transport form of iron, no, that's also low. Transferrin saturation is normal or low. This is anemia of chronic disease. Versus low hematocrit, low MCV here as well. High transferrin, which is a storage form, is high here. We have enough. No, this doesn't sound right. High TIBC plus transferrin saturation super low. This is iron deficiency anemia. Transferrin is the transporter. So that's high in transferrin, in iron deficiency anemia. Okay, one more time. Low hematocrit, low MCV. Yes. Low hematocrit, low MCV, mean corpuscular volume, low transferrin, which is the transporter in the blood. So this has enough. The transporter is low. Low TIBC, which is low saturation. No, transferrin is the same thing actually as TIBC. Okay. Low transferrin or TIBC. Transferrin saturation is normal or low. That is anemia of chronic disease. Versus low hematocrit, low MCV, high transferrin and high TIBC. Transferrin saturation is super low. This is iron deficiency anemia. High transferrin or TIBC. So when the word saturation comes, it becomes super low in IDA. Okay. Next is low hematocrit plus low MCV plus increased RDW. This is iron deficiency anemia. Low crit, low MCV, low to low normal distribution width is thalassemia. This is important. Increased RDW is always IDA. Low to low normal RDW is thalassemia. Low hematocrit plus low MCV plus low iron and ferritin is iron deficiency anemia. Low hematocrit plus low MCV plus normal iron and normal or high ferritin is thalassemia. So IDA versus anemia of chronic disease, iron deficiency anemia versus thalassemia. So here the difference is the transferrin is low and transferrin saturation is normal or low. So low, normal or low for anemia of chronic disease versus in iron deficiency, high transferrin, high TIBC, saturation is super low. So that's IDA versus ACD. Now we have IDA versus thalassemia. The distribution width is high in iron deficiency anemia versus low to low normal in RDW in thalassemia. Iron can be normal in thalassemia. So if you have a microcytic but normal iron, think thalassemia. Ferritin can be normal or high. Then low hematocrit plus low MCV plus normal iron plus normal ferritin in pregnant women on iron supplements. Think thalassemia. She's already taking iron supplements and her ferritin is also normal. So she should not be iron deficient. So this is implying it is thalassemia. Then microcytic anemia that doesn't improve with iron supplementation, also think thalassemia. Diagnosis of thalassemia is with hemoglobin electrophoresis. Okay. Last 4 pages. Okay. Okay. Page 16. Low hematocrit plus normal MCV plus low iron plus normal or high ferrit plus normal or high ferritin. That we just did this anyway of chronic disease. Okay, I guess he's reinforcing it. Low hematocrit. Okay, he's trying to say that it can be normal MCV also for ACD. Okay. Okay, got it. So, low hematocrit, normal MCV plus low iron plus normal or high ferritin is ACD. Then treatment of anemia of chronic disease if renal failure is the cause. Answer is EPO. Give erythropoietin. Okay. Treatment of anemia of chronic disease is renal failure is not the cause. Like if it is IBD, inflammatory bowel disease, rheumatoid, SLE, cannot give EPO. Treat the underlying condition. So in the case of renal failure, give EPO. Otherwise, treat the underlying condition. Next is high blood pressure plus smoker plus TIA or stroke or retinal artery occlusion. How to best decrease stroke risk? Answer is lisinopril, not smoking cessation. Stroke is always blood pressure. BP सिर पे चढ़ जाता है, if you know good Hindi Urdu. So answer is lisinopril to reduce the blood pressure, not smoking cessation. Normotensive old patient plus TIA or stroke or retinal artery occlusion. AFib. Normotensive old patient. So BP is not the reason here. But patients having a TIA or a stroke or a retinal artery occlusion. What are we thinking? AFib is throwing a clot causing an occlusion, causing a stroke. Okay. Then hypertensive patient plus stroke, do a carotid Doppler ultrasound. Normotensive patient plus stroke, do ECG. If ECG is normal, then do a Holter monitor. Then high blood pressure, high BMI female plus irregular menstrual cycles and ovulation. Okay, now we move to gynae. High BMI female plus irregular menstrual cycle is anovulation. Anovulation plus hirsutism, think PCOS. Anovulation. The cause that USMLE wants is insulin resistance. Insulin resistance causes abnormal GnRH pulsation. Why hirsutism and anovulation? Abnormal GnRH pulsation causes high LH and FSH ratio. This is also a question. High LH in an ovulation. Why high LH FSH ratio is important in ovulation or PCOS? Ovulation stimulated when follicle not ready. So no anovulation leading to follicle retained as a cyst. Okay. High luteinizing hormone and ovulation is stimulated when the follicle is not ready. So that unprepared follicle now becomes a cyst. So polycystic ovaries. What's LH do? LH stimulates the theca interna cells in females and Leydig cells in males to make androgens. So it makes sense that the LH ratio is higher. What does FSH do? It stimulates the granulosa cells in females and Sertoli cells in males to make aromatase. Also primes the follicles. Then treatment for PCOS, if high BMI, then weight loss is always first on USMLE. Treatment for PCOS, if they ask for meds and or weight loss already tried, then OCPs. If not wanting pregnancy, and clomiphene if wanting pregnancy. PCOS increases risk of what? Endometrial cancer due to unopposed estrogen. What is the treatment next? What is the treatment of prostate cancer? It's flutamide plus leuprolide together. If they force a sequence, then choose flutamide first. Okay. Treatment of acute gout, indomethacin first on USMLE, then steroids, then colchicine. Treatment of acute gout is indomethacin plus steroids is not listed, then choose colchicine. Treatment of acute gout in patient with renal insufficiency or history of renal transplant. Treatment of acute gout in patient with renal insufficiency or history of renal transplant, give steroids. Treatment of chronic gout for disease recurrence, then we give allopurinol or febuxostat, which are xanthine oxidase inhibitors. Never give which drug to patient. What? Okay. Question asks, never give which drug to patient with a history of uric acid stones or overproducer. Probenecid, uricosuric. Patient already has uric acid stones. If you're going to give probenecid, it's a uricosed uric acid. It's going to shunt all the uric acid to the urine and cause more uric acid stones. So it makes sense we don't give it. So what are rasparicase and pegloticase? These are urate oxidase analogs, cleave uric acid directly. So we would give it I guess if you're expecting lots of cellular breakdown after chemo and stuff. Okay. Then next page, 16. Young kid plus self-mutilation plus red-orange crystals in diaper. This red-orange crystals in diaper is buzzword for Lesch-Nyhan syndrome, which is X-linked. Lesch-Nyhan enzyme is HGPRT deficiency. Usually enzymes are autosomal recessive, but this is X-linked, so we should remember this. What is HGPRT? Hypoxanthine guanine phosphoribosidal something. Transferase or whatever that is. So HGPRT deficiency, crystal type and pseudogout, calcium pyrophosphate deposition disease, CPPD. Two main causes of pseudogout are primary hyperparathyroidism plus hemochromatosis. I guess somewhere he also said hypothyroidism can sometimes cause pseudogout. Two-way pseudogout presence. Monoarthritis of large joints, that is knee or osteoarthritis-like presentation in someone with primary hyperparathyroidism or hemochromatosis. Next, we have 32 male plus dark skin on forearms. Increased fasting glucose. Diagnosis is hemochromatosis. The dark skin on forearms is bronze diabetes. Okay. Where was I? Bronze diabetes. Small male, painful, sorry, same male with painful hands plus X-ray shows DIP involvement. Joint pain. What's the diagnosis? Pseudo gout. Okay, yeah. So hemochromatosis, presenting with the DIP involvement, it's because of pseudo gout. So 32-year-old male with dark skin on forearms, increasing fasting glucose, has painful hands, X-ray shows DIP involvement. What's the joint pain diagnosis? It is pseudo gout. Next, treatment of pseudo gout is same as gout acutely and treat the underlying condition for chronic. What's the biggest risk factor for osteoarthritis is obesity. Treatment for osteoarthritis is weight loss. If normal BMI, then acetaminophen before NSAIDs. This has always been a point of difference between NBME and AMBOSS and UVOLT. But thankfully, in so far in NBMEs 9 through 14, I've noticed that if they give a history of gastric ulcer, then we're avoiding NSAIDs, so we would pick acetaminophen. Otherwise, there's, or if they give ketorolac, which is an IM form, then we're going to start with oral drug, which is acetaminophen. So keep that in mind. Patients with OA taking naproxen, NSAID plus peripheral edema. Why? It's because of increased renal retention of sodium from the NSAID. Patient taking an NSAID plus edema. Why? So NSAID decreases the renal blood flow, leading to, once again, patient taking edema, NSAID plus edema. What's the reason for the edema? Increased renal retention of sodium. So how does this happen? NSAID decreases renal blood flow, which leads to PCT increases the sodium reabsorption to compensate for perceived low volume status. So sodium increase, PCT increases sodium resorption. If we increase sodium, water follows. So we have edema. Next, treatment of rheumatoid arthritis is two-armed. One, you have symptom relief plus DMARDs. Symptom relief for RA, NSAID first, then steroids. These take care of the symptoms only. They do not slow disease progression. DMARDs for early RA, always methotrexate first. If insufficient, then add another DMARD like sulfasalazine or leflunomide. If insufficient, then further add TNF alpha. So methotrexate first, then another DMARD which is sulfasalazine or leflunomide, and then it is TNF alpha agent. Methotrexate mechanism of action, dihydrofolate reductase inhibitor. Methotrexate side effects are pulmonary fibrosis, hepatotoxicity, and mouth ulcers because of neutropenia. Then sulfasalazine mechanism of action is metabolized into sulfapyridine plus mesalamine in the gut by bacteria. Mesalamine is a 5-aminosalicylic acid absorbed as the treatment for RA. Only NSAID considered to be a DMARD. Then we have leflunomide mechanism of action, which is a dihydroorotate dehydrogenase inhibitor, pyrimidine synthesis. Most specific antibodies in RA is anti-CCP, anti-citrulline cyclic citrullineated peptide, not RF. RF is non-specific, but sensitive. So most specific is anti-CCP. X-ray of hands in RA versus OA. Only osteoarthritis has DIPs involved. So osteoarthritis is distal. RA is PIP plus MCP. Symmetry in RA versus OA. Rheumatoid is symmetrical, makes sense because it's an autoimmune pathology. It's going to be all over the place, or I mean, both sides. OA is asymmetric. Then any patient with red, warm, tender knee, do a joint aspiration, arthrocentesis. It is septic arthritis until proven otherwise. Biggest risk factor for septic arthritis is abnormal joint architecture. So any underlying trauma or OA or RA can predispose to septic arthritis. So red, warm, tender, do an aspiration arthrocentesis. Patient group most likely to get SA, septic arthritis, is those with prosthetic joints, RA, OA, recent intense exercise regimen. Didn't know about this. Didn't think of that. Recent intense exercise, joint trauma. PEDS, it is juvenile rheumatoid arthritis. Next patient, next page 18. Patient group most likely to get septic arthritis. Okay, continuing on. Those with prosthetic joints can't be more abnormal than a fake joint. Haha. Okay. Patient with OA or RA has a red, warm, tender knee. Do arthrocentesis, septic arthritis. Next, 17 female had kickboxing tournament last weekend. Red knee is a red, warm, and tender. Next step, do arthrocentesis or septic arthritis. Kickboxing. But now the knee is red, warm, and tender. Okay. Anytime the knee is red, warm, and tender, just do arthrocentesis. Next, kid plus recurrent knee redness, warmth, pain, and fever. Juvenile rheumatoid arthritis, still disease, also known as still disease. Okay. Different from Still's murmur, I guess. Yeah. Still disease. Then kid plus recurrent joint pain, plus or minus high ESR, plus or minus rash is also JRA. Kid plus recurrent joint pain plus anemia, JRA due to anemia of chronic disease. Kid plus suspected JRA has a sore knee, must do arthrocentesis to rule out septic arthritis. So basically, presentation is kid with the red knee, kid with joint pain, high ESR plus or minus rash, kid with joint pain plus anemia with JRA plus ACD. Okay. Anytime kid with suspected JRA has a sore knee, must do arthrocentesis to rule out septic arthritis. Most common presenting finding in SLE is arthritis, more than 90%. Women 20 to 40s plus arthritis plus thrombocytopenia, think SLE. Women 20 to 40s plus arthritis plus a mouth ulcer plus circular skin lesions, also think SLE. Malar rash plus low RBCs plus low WBC, low platelet. What is the mechanism for low cell lines? Increased peripheral destruction. Really? You know this. Increased peripheral destruction. Why? Because the antibodies against hematologic cell lines are seen in SLE. Isolated thrombocytopenia is most common. Treatment of SLE flare, steroids. Yes. SLE plus red urine. Yes, lupus nephritis. More specifically, diffuse proliferative DPGN, diffuse proliferative glomerulonephritis. History of DPGN while looping, and step one, we used to remember lupus has the wire looping, right? Capillary pattern. Then treatment of lupus nephritis is mycophenolate mofetil, MMF. Treatment of, okay, this is for the kidney. Lupus nephritis is MMF. Treatment of discoid lupus is hydroxychloroquine. Most specific antibodies for SLE is anti-Smith, RNP ribonucleoprotein, not anti-dsDNA. Really? I thought they were both specific, but most specific is Smith. Mr. Smith is most specific. Okay. Which antibodies go up in acute SLE flares is anti-dsDNA. C3 goes down. Okay. Drug-induced lupus antibodies is antihistone. Yes. Drugs that cause DIL, which is drug-induced lupus. MOM is HIP. Minocycline, hydralazine, INH, Procainamide penicillin. Mom is hip. I think they had a different mnemonic in step one. Isn't it like ships or something? Anyway, mom is hip. What is this mnemonic for dill? Okay. Minocycline, just like a tetracycline, hydralazine, isoniazid, procainamide, penicillamine. Viral infection plus all three cell lines are down. Viral induced aplastic anemia. Viral induced aplastic anemia, next best step in diagnosis, do a bone marrow aspiration. Oh, poor guy, got a viral infection, now needs a bone marrow aspiration. Viral induced aplastic anemia mechanism, defective bone marrow production. Contrast with SLE, where they said it was destruction. Viral induced aplastic anemia mechanism is defective bone marrow production. Contrast with SLE, where there was increased peripheral destruction because these antibodies go and destroy the cell lines. Okay. Next, viral infection plus low platelets. Isolated low platelets is ITP, immune thrombocytopenic purpura. Okay, labs will show isolated decreased thrombocytes. Women 30s to 40s with random bruising at different stages of healing. Also ITP, but first rule out abuse. Yes. Mechanism of ITP is GP antibodies against GP2B3A on platelets. Diagnosis of ITP, low platelet count. Don't choose increased bleeding time. Haha, yes, very important. Isolated low platelets, don't choose decreased. Don't choose increased bleeding time. ITP treatment is steroids first, then IVIG, then splenectomy. I think we said this mnemonic. ITPs treat with cis. Steroids, IVIG, splenectomy. ITP 123 SIS. Okay. ITP episode. Next best step in management, give steroids, which is number one. ITP episode, most effective way to decrease recurrence. Recurrence, when they talk about it's splenectomy, which is not first line, but it's most effective. Excuse me. Okay, family history of heme condition treated with splenectomy is hereditary spherocytosis, autosomal dominant. So I guess the weird way of asking. There's a family history of some heme condition. They treated with splenectomy. What is this condition? It's hereditary spherocytosis, which is autosomal dominant. Bleeding time, meaning it's a platelet problem. PT and APTT, meaning clotting factor problem. Yes. Heme findings in ITP. There is increased bleeding time. Normal PTT and PTT. Normal PT and APTT. But for diagnosis, don't say increased. Don't choose increased bleeding time. More specific is low platelet count. Noise. So one more time, heme findings in ITP is increased bleeding time, normal clotting stuff. So normal PT and APTT. Heme findings in hemophilia, increased APTT. Hemophilia is factor 8. We played tennis. What was it? Play tennis outside, extrinsic. Play table tennis inside. This is intrinsic. What was it? I forgot. One second. Mm. So it was 5 to 1. So 5 times 2 is 10. And then we have 3 plus 7 is 10. Then we have 12, 11, 10 is here. So 9 and 8. This is all intrinsic. This is extrinsic. This is common. Two common pathway. 2 was thrombin. 1 is fibrinogen. So 12, 11, 9, 8. So factor 8 is hemophilia. 9 is that Christmas disease. Yeah. Why did I do this? To say that a intrinsic is play table tennis inside, which is intrinsic. So heme findings in hemophilia has increased APTT, bleeding time and PT are normal. Cause of hemophilia, this is X-linked recessive. Hemophilia A is a factor A deficiency. Hemophilia B, okay, yeah, B, which Christmas disease is factor 9 deficiency. Treatment of hemophilia A. First, give desmopressin for hemophilia A. Why? Because it will release factor 8. Then replace with factor 8, recombinant factor 8. Treatment of hemophilia B, we directly give recombinant factor 9. We don't have any other option. Okay. Next one. Classic hemophilia presentation. Hemarthrosis in a school-age boy. Bleeding after circumcision in neonate. So joints bleed, right? Hemarthrosis in school-age boy or bleeding after circumcision in a neonate. Think hemophilia, classic presentation. Inheritance pattern of von Willebrand disease. Now we move to von Willebrand disease, which is autosomal dominant. So we have hereditary spherocytosis is autosomal dominant. We have hemophilia, which is X-linked recessive. Then we have von Willebrand disease, which is autosomal dominant as well. So heme findings in von Willebrand disease, bleeding time is always high. PT is always normal. APTT is elevated half the time. Because von Willebrand is related to factor 8, right? So heme findings in von Willebrand disease, bleeding time is always high. PT is always normal. APTT is elevated half the time. What is the main function of von Willebrand factor? It bridges platelet GP1B to the underlying collagen. So it is responsible for adhesion, not aggregation. GP1B to collagen. What is the main function of von Willebrand factor? Bridges GP platelets GP1B to the underlying collagen in the vessel. So the job is adhesion, not aggregation. Next, what is the secondary function of von Willebrand factor? It stabilizes factor 8 in the plasma. That's why APTT is only half time increased. Then von Willebrand disease presentation, always one platelet problem plus one clotting factor problem. Nice. So one platelet problem, which is epistaxis, bruising, or petechiae, generally mild and cutaneous, and one clotting factor problem, which is menorrhagia, excessive bleeding with tooth extraction, or hemarthrosis. But hemarthrosis is very, very rare in von Willebrand disease. It is usually seen in hemophilia. Okay. So epistaxis, bruising plus petechiae, which is platelet, plus menorrhagia, excessive bleeding, and tooth extraction. If both are there, think von Willebrand presentation. Hemarthrosis is very, very rare in von Willebrand. It's more with hemophilia. Next, von Willebrand treatment is desmopressin. Why? Because it will increase release of von Willebrand factor. Then vitamin K deficiency, heme parameters. Vitamin K deficiency. K is responsible for factors 2, 7, 9, and 10 thing, right? So factors 2, 7, 9, and 10. So increased PT plus APTT are increased. Bleeding time is normal. This is very important because bleeding time is a platelet problem. So here platelets are okay. It's the factors 2, 7, 9, and 10. So one more time we had factor 10 in the middle. 5, 5 and 2 into 1. And we had 7 plus 3. And we had 12, 11, 10 is here, 9 and 8. This is intrinsic. This is extrinsic. This is common. We play table tennis inside. We play tennis outside extrinsic. So for vitamin K we have 2, 7, 9, and 10. So all the pathways, right? So APTT and PTT both will be increased. Bleeding time will be normal. Next, we have causes of vitamin K deficiency in adults. Chronic antibiotics knock out colonic flora. Yes, in adults, vitamin K deficiency. Yeah, when we take antibiotics, it will knock out colonic flora. So we don't have anything to absorb the vitamin K. Cause of sickle cell. Glutamic acid 2-valent mutation on beta chain. Inheritance of sickle cell is X-linked, autosomal recessive. Sickle cell disease was autosomal recessive. Nephrotic syndrome in nephrotic syndrome in sickle cell is focal segmental glomulosclerosis. Dark urine in SS is due to renal papillary necrosis. High yield drug that cause agranulocytosis. Clozapine, ganciclovir, propylthiouracil, methimazole, methotrexate, diclopidine. What is this? What about that? Okay, clozapine, ganciclovir. So some psych history, CMV history, thyroid, metho for rheumatoid maybe, and diclopidine is given for what? Antiplatelet. Oh, clopidine, like clopidogrel, okay. How will agranulocytosis neutropenia present on USMLE? Mouth ulcers plus fever. Treatment for febrile neutropenia or neutropenic fever, immediate broad spectrum IV antibiotics. Broad spectrum antibiotics example is Piptaz, piperacillin tazobactam, or cefepime plus vancomycin. What is ganciclovir used for? Treatment of CMV, which is a DNA polymerase inhibitor. PTO and methimazole are used for what? Treatment of Graves. Diclopidine is what? Okay, you mentioned it here, nice. ADP2Y12 blocker, antiplatelet agent, like clopidogrel. It has clop in it. So clopidogrel, prasugrel, ticagrelor also. Strongest indication for anticoagulation is prosthetic material in heart, prosthetic valve. It's a factoid in isolation. Okay. Strongest indication for anticoagulation is prosthetic material in heart or a prosthetic valve factoid in isolation. And we are done with part 1. Yes, all materials copyright and property of Mehlman Medical. Thank you, Mehlman Medical. So that ends part 1 of the high yield review. See you tomorrow. Thank you so much. Bye-bye.